One of the most stressful OET speaking scenarios for experienced international medical graduates is this. You present a clear, medically necessary treatment plan, like urgent hospital admission or starting statins, and the role-play patient flat out refuses. They look at you and say, "I don't have time for the hospital, doctor. Just give me some strong painkillers so I can get back to work." Panicking under the 5-minute clock, candidate doctors usually fall into one of two pitfalls. They either enter an aggressive medical argument, or they surrender completely and give the patient whatever they want. Holding either instinct introduces an immediate, high-risk liability under official marking criteria. In this masterclass, we are going to break down why patient refusal causes instant timeline collapse and install a 3-step boundary control protocol to manage pushback with total authority. Pay close attention when we reach step 2 of this protocol, as I will reveal a subtle 2-word phrasing shift that satisfies incorporating patient perspective instantly, without giving away a single second of your clinical runway. To understand why competent doctors struggle when an OET patient pushes back, we have to look at real-world hospital conditioning. In daily ward practice, when a patient refuses critical care, you have time to bring in senior consultants, talk with family members, or document refusal of treatment forms over several hours. But under the psychological pressure of a timed 5-minute simulation, those real-world habits fail you. Doctors usually slip into one of two damaging patterns on their scorecard. On one hand, you might try to convince the patient using dense clinical risks. The patient digs in, objects again, and bleeds 2 minutes off your clock, while your score in providing structure plummets. On the other hand, you might try to avoid conflict by immediately capitulating to unsafe patient demands. That drops your marks under information giving because you failed to explain essential safety boundaries. To master patient pushback, you must understand how the interlocutor's role-play card is actually engineered behind the scenes. On test day, the interlocutor is holding explicit script prompts. When a scenario involves pushback, their card contains a directive, instructing them that if the doctor ignores their concern or uses heavy medical pressure, they must continue to object. This means when you respond to pushback with medical arguments, you are actually forcing the interlocutor to execute their objection prompt. That triggers a brutal double penalty on your mark. You lose points under relationship building for dismissing their emotional state, and you simultaneously lose points under providing structure because the resulting argument destroys your 5-minute timeline runway. Before we look at the exact 3-step protocol to solve this, don't guess whether your consultation timeline is leaking under patient pushback. I built a free 60-second interactive audit that calculates your exact risk score based on your real practice habits. Select the structural liabilities you drop on test day, get your instant risk diagnostic, and unlock the complete clinical framework breakdown. Pause this video now, click the link in the description below, run your 60-second audit, and let's jump straight into the solution. To neutralize patient pushback without arguing or surrendering, we replace emotional debates with a fixed operational framework called the 3-step boundary control protocol. First, we validate without exceeding. You acknowledge the patient's emotional or practical barrier immediately before offering any clinical counterargument. Second, we isolate the core concern. This is where we deploy that phrasing shift I mentioned earlier, using the exact 2-word pivot. What specifically? By asking what specifically concerns them most about spending the night in the hospital, you extract their actual fear, whether it is childcare, job security, or a needle phobia. This completely satisfies incorporating patient perspective without losing time. Third, we reframe the boundary. You offer a structured, conditional compromise that maintains clinical safety while respecting patient autonomy. Here is the exact verbatim script you deploy when a patient refuses hospital admission or urgent investigation. I completely understand that taking time off work feels impossible right now, Mr. Murphy. However, my primary responsibility today is ensuring your safety. What specifically concerns you most about spending a few hours in the clinic for these tests? I see. What we can do is run the initial blood markers right now, and if those return clear, we can discuss a managed home treatment plan with strict safety nets. Notice the specific rubric criteria this exchange satisfies. Opening with immediate validation acknowledges their distress and satisfies relationship building without yielding clinical control. Pivoting with what specifically isolates the true barrier in a single sentence, preventing an open-ended argument loop. Finally, proposing a conditional test plan establishes clear boundaries, protecting providing structure while maintaining your authority as a senior clinician. You must view this protocol within your 5-minute consultation timeline. Our framework allocates minute 0 to minute 1 for clinical control, minute 1 to minute 3 for targeted exclusion, and minute 3 to minute 5 for collaborative management and boundary control. If you hit patient pushback at the 3-minute mark and enter a 90-second argument, you bleed your entire stage 3 runway. You run out of time to execute your final sweep or deliver safety netting, resulting in an automatic score cap. Deploying the 3-step boundary control protocol resolves pushback in under 30 seconds, preserving your final sweep at 4:30 and locking in your grade B+. Now, I want to audit your specific test day friction points. Drop a comment below telling me which pushback scenario causes you the most anxiety when nervous, whether it is an angry parent refusing pediatric vaccinations or a demanding patient insisting on unnecessary antibiotics. I personally review and reply to your comments to help you troubleshoot your consultation phrasing for test day. And if you haven't run your diagnostic yet, click the link in the description now. Take the 60-second Timeline Integrity Audit and secure your consultation structure before your next practice session. I shall see you in the next masterclass.